after surgery for aortic aneurysms. Both of these papers are extremely exciting, and I am quite looking forward to the discussion that is generated. Thank you to the people who are involved. Thank you to Mass General, Dr. Dua, and Dr. Mulaney Topka for presenting the first paper, and to the University of Maryland, Dr. Nagarset and Dr. Martinique Lamb for doing the second one. We always are really glad when our authors can join, and thank you to Dr. Dunham and Dr. Lee for being here, and to Dr. Darling and Dr. Standenberg too for the second paper. A special welcome to our moderators, Dr. Syracuse and Dr. Suko. Thank you for joining. And before we get started here, just a few housekeeping comments. Please do stay muted and put your questions or comments in the chat. The moderator will call on you to speak. The event is, of course, being recorded for on-demand access. We will, I think the rest of it is just housekeeping, but the next month's meeting, I think, is on the 19th, and you can find the information at vascular.org. And the topic's not yet been posted, but they will be available soon. So with that, I'd like to hand the floor over to our first paper. Let me stop sharing here, and the floor is turned over.
Do you want us to talk about the best CLI paper?
Yes, thank you.
Yes.
Got it. Okay. Can you all see that?
Yep.
Okay,
Good.
cool.
Thank you.
Great.
All right. So good evening, everybody. I'm KJ Nagerseth. I'm here at the University of Maryland, along with our fellow Martinique Lamb, who's going to be discussing the paper. For those of you that have seen me on this before, I apologize in advance because I have a dog who has a lot to say when I get home, and so you may hear him as well. But this is just this is the validation of the best CLI among patients undergoing primary bypass or angioplasty with or without being without stenting for chronic limb ischemia. These are just some of my introductory thoughts on the paper and on the problem. So the clinical problem, what is the optimal method for lower extremity revascularization in patients with CLTI? Is it open bypass with a single segment great saphenous vein, or is it something percutaneous, either angioplasty plus or minus stenting? Are the findings of the best CLI study, which we all know is a landmark study, is it generalizable to the real world practice that we all see every day? So that's the clinical problem. So I decided to go through some of the methodological considerations for RCTs in general. Randomized control trials, they're the foundation of what we use in terms of evaluating treatment strategies and guiding our practice. They involve multiple arms involving comparison between different treatment groups and outcomes. And anyone who's designed these studies, you understand that designing and conducting an RCT, it requires a lot of thought and consideration to really make sure that the results you're going to get are robust and clinically relevant. And this is where the art of designing a study comes into play. So these are all things we think about when we're designing studies, and we have to consider this when we read studies. Is this applicable to what we actually do? The issue really is, are trial populations representative of real world patients? This is a concern that I have, that most clinicians have. We read these trials, we understand landmark trials, but when you look at the patient population and you look at the variables that are looked at, these are very controlled situations. The patients are very controlled. The variables are very specific, and the experiments are designed in such a way to answer a very specific question based on the study design, right? And you really want to avoid any unforeseen bias in these patients, in these trials. So is this truly what we see every day? You know, you read some studies in PAD, and they're looking at SFA lesions under 10 centimeters in length. You know, minimal calcification, excellent 3-vessel runoff. Is this truly a real world patient? That's what you have to ask. And that's what I think this paper did a good job of. And we'll go through that here in a second. The clinical gaps to fill. There's a lack of external validation for best CLI trial findings in the broader real world patient population that is not trial applicable, people that might not have been included in the trial, is this representative of what we see out there? And even though Best CLI is a landmark RCT, its strict inclusion and exclusion criteria, the controlled environment in which we're doing these things, and the patient selection, that really could limit its applicability to our real world patients. The study here really aimed to fill that clinical gap. And with that, I will turn it over to Martinique.
Unmute. Are you able to hear me now?
Yes, you're all set. Thank you.
Okay. So thank y'all for allowing me to present. As Dr. Nagersheth said, I'm going to be going over the study that looks at the validation of Best CLI amongst patients undergoing primary bypass or angioplasty with or without stenting for chronic limb-threatening ischemia. So introduction, we all know that Best CLI was a randomized controlled trial published in 2022, and it advocates for superiority of single segment greater saphenous vein bypasses in comparison to percutaneous transluminal angioplasty with or without stenting in patients with CLTI. The study, however, was very highly selective, as Dr. Nagersheth said, very highly controlled, and it had a very strict follow-up protocol. So the real question is, can this be replicated in our real-world practices? Is this advice that we can take for our day-to-day patients? So when looking at the methods for the study, it was a retrospective review at a single site, and it looked at patients that had been intervened upon between the years of 2005 and 2022. Its inclusion criteria were that the patients had to be undergoing their very first intervention for lower extremity in CLTI, and that's defined as rest pain or tissue loss. The exclusion criteria is that they'd had any previous ipsilateral limb intervention or any suprainguinal intervention. And the primary endpoints that it wanted to measure was wound healing, any reintervention, major amputation, and major adverse limb events. So that is defined as above knee amputation, untreated target vessels, bypass graft occlusion after your intervention, as well as lysis. And death. So it also looked at two separate time periods. So the immediate perioperative outcomes, which were up to 30 days, and the long-term outcomes, which were up to 7 years of follow-up. It's set to mimic the Best CLI study as best as it can. So the outcomes were assessed, and they were looking at MI, stroke, access site hematoma, surgical site intervention or infections, and major reinterventions in those first 30 days. So of note, the choice of intervention was surgeon dependent, as it was a retrospective study. The interval follow-up time was about 3 to 4 months for the first 2 years and then 6 months thereafter. And they were evaluated with arterial duplex, ABIs, and toe pressures. So looking at this study in comparison to Best CLI, it's very similar. It's set to set up the same cohorts. So you can see that cohort 1 for this study included all patients undergoing single segment greater saphenous bypass graft in a matched cohort in comparison with the angioplasty plus or minus stenting, which is similar to the cohort 1 for Best CLI. When coming down to cohort 2 for this study, it looks at patients who do not have a single segment greater saphenous availability. So they're having to use splice, arm vein, or prosthetic conduit, and they're comparing those with their counterparts for the angioplasty and stenting patients. So I've included this for completeness, just for the analysis sake, and then moving on to results. So in this retrospective study, about 2,000 patients were identified, and you can see here the groups that they fell into as far as bypass graft versus angioplasty and stenting, and they were broken up into cohort 1 and 2. Cohort 1 being a little heavier, however, they all have equal amounts of patients in their groups. Of note, there was no drug-coated balloons or drug-eluting stents in the angioplasty stenting groups. The median follow-up in both cohorts was about 2.7 years, and they were roughly equal as far as comorbidity distribution, gender, and ethnicity. So when we're looking at the results for each individual cohort, we'll go through them one by one. So out of the almost 900 patients in cohort 1, there was no significant demographic or anatomic characteristics that were different between the two groups. The mean age was about 70 years, and when looking at their comorbidities, their gender, and their sex, they were roughly all the same as displayed here. The most common indication for intervention was tissue loss, roughly about 81 and 82% in both groups respectively. And the most common lesion that was encountered in both treatment modalities was a TASC-B lesion. When looking at their perioperative medications, there were no significant differences between the two groups. So looking at that first 30 days, the bypass graft as compared to angioplasty plus or minus stenting demonstrated lower rates of any reintervention as well as major reintervention. There were no differences noted, however, between the two groups when evaluating perioperative outcomes such as MI, stroke, or mortality. Surgical site infections occurred in about 9.5% of the bypass patients, and when looking at access site hematomas, about 4% in the angioplasty stenting patients. Now looking at long-term outcomes, following these patients out to about 7 years, between the bypass graft and the angioplasty stenting groups, no differences were seen in complete wound healing at 6 months, nor in the major rate of amputation at 7 years of follow-up. Both any reintervention and major reintervention, however, were significantly lower in the bypass group. And they had a 27% and 53% risk reduction as compared to the angioplasty and stenting group. When looking at their mall-related death, they also had a lower rate with a 28% risk reduction. So we're seeing less interventions in the bypass group as well as less mall-related deaths. There was no difference noted between the two groups when looking at their major amputation related deaths at 7 years or their all-cause death. So here is just a schematic. You can see this first one here on the left, the major reintervention, and the patients associated with their follow-up up to the years. So 7 years here. This red mark is for the bypass group. So you do see that you have lower rates of major reintervention in this particular study group. Over here, major adverse limb events and their related deaths. As time goes on, it does go up for both groups, but you do have lower rates for the bypass group. So now looking at cohort 2 and just briefly re-summarizing, this is for patients who did not have a single segment bypass graft available. So they're using spliced veins, arm veins, or prosthetics. So almost 300 patients here. Once again, no demographic or anatomic characteristic differences between the two groups. Mean age was roughly the same as with cohort 1. And the distribution of comorbidities was roughly the same in both groups being evaluated here. The most common indication, once again, was for tissue loss. However, the difference with cohort 2 is that TASC-D lesions were more common, lesions encountered in the bypass group. So these are more severe lesions, more commonly treated with bypass, whereas TASC-B lesions were the more common lesions encountered for the angioplasty plus or minus stenting group. And once again, perioperative medications really were no different between the two. So looking at the bypass patients in cohort 2, the inflow vessel most commonly used was the common femoral, whereas the most common outflow target was above knee. And this was made note of. There were lower, I guess I'll get into that a little later, but above knee bypasses for the most part. Over 1/2 of the bypass graft interventions utilized prosthetic conduits, about 60%. And among the angioplasty and plus or minus stenting procedures, 56% involved angioplasty alone, whereas 44% included stenting of one or more vessels. The most common proximal vessel intervened upon was the SFA, whereas the most common distal was the AT. And when looking at the angioplasty stenting group, 25% were multi-level interventions. So once again, looking at the 30-day outcomes, the immediate perioperative period, the bypass group, as compared with the angioplasty stenting group, demonstrated a trend towards lower rates of intervention, reintervention, and significantly lower rates of major reintervention. There were no significant differences noted between the bypass graft and the angioplasty stenting in other perioperative outcomes, which was similar to cohort 1. And then the surgical site infections occurred in about 8.8% of the bypass patients, whereas access site hematoma occurred in 6% of the angioplasty stenting patients. Looking at their long-term outcomes, between the bypass graft and the angioplasty stenting, there were no significant differences long-term seen in complete wound healing rates at 6 months, nor in the rates of major amputation, reintervention, major reintervention, amputation-related death, MALS-related death, or any all-cause death. So across the board, fairly even. As with cohort 1, similar subgroup analysis were performed within cohort 2 to assess the potential treatment effect across the same pre-specified groups regarding MALS-related death. And ultimately, the recommendation and the data showed it was far more neutral than that of cohort 1, but did slightly favor bypass graft. Notably, the patients who did have lower rates of MAL-related death, they were patients who were older than 80 and those who didn't have diabetes. So I just inserted this here, mostly to look at the rates of reintervention in cohort 1 when comparing the bypass graft patients, as opposed to the angioplasty and stenting alone, significant lower rates within the bypass here. So overall discussion, looking at the replication of the best CLI in a single site study, I think that it did a fairly good job of recreating this. So the conclusions of this study that single segment greater saphenous vein for first time revascularization in CLTI patients has an overall 53% lower reintervention rate. And a 28% lower MAL-related death rate as compared to the angioplasty and stenting group, which is highly favorable for these patients who are already so sick. After matching patients undergoing bypass without a single segment greater saphenous vein as compared to the angioplasty plus or minus stenting, there was no significant difference seen in any of the assessed outcomes, including one of the things we look at most, which is the major reintervention, as well as the MAL-related death. So ultimately, is best CLI applicable in real world populations? And I think that this study was able to prove that it was. Just looking at limitations, strengths overall for this study, I think the strengths were appropriate. It appropriately mimicked and recreated best CLI using the data that was available for this institution, compared both the greater saphenous and non-greater saphenous conduits, similar to the best CLI trial. So it was really able to give us an idea that we are able to recreate this in our day-to-day practice. Looking at limitations, it was a retrospective single site study, so there is some error imparted, I think, from bias. And in the discussion of this article, it does say itself that it's based on referral patterns and surgeon preferences. So there is some innate bias there. Differently from the best CLI paper, there was no preoperative vein mapping prior to intervention selection, which was something that was present in the best CLI paper, but this being retrospective, it was not something that was included. And I think more so, just talking generally, the study selects patients with CLTI without previous interventions, which I think sometimes can be a rarity in our practices and our clinics. We're seeing patients with a lot of previous interventions. So it's a very specific patient that we're looking for when applying the data that we're finding from these studies. And still, once again, like best CLI, it fails to provide a really good, strong recommendation for patients who don't have a suitable single segment greater saphenous vein conduit. Thank you.
Great presentation. Really nice job. We'll take questions if you have them. Put them in the chat, please. I think my first question for Dr. Darling, what were the biggest constraints in the best CLI trial, with being a randomized trial that we addressed before, that you think you were able to overcome and expand on in this analysis?
I think the big thing is, first of all, I want to always say thank you to all the investigators, researchers, and collaborators for best CLI. It's an unbelievable study that we hope is, effectively disseminated throughout clinics in the country and in the world, because we think it's a really important study that shows how we should approach this pretty complex patient population. We think it has a lot of really, really wonderful strengths. And thank you for the wonderful presentation, Dr. Lamb. That was really thorough. I think the big thing that we feel this study did in terms of expanding on Best CLI is kind of, as was mentioned several times, incorporating the inclusion exclusion criteria as best we could with the retrospective design among a kind of quote unquote real world population. And I think that's reflected most notably through the increased dialysis dependence, increased CAD rates, increased rates of non-white patients, just sort of a generally sicker patient population that I think is not as reflected in these randomized control trials, where often it's a much more kind of rigorous, closely followed group of patients who have, I think one of the other things that's important is that they don't have, they have a life expectancy over 2 years in Best CLI, and we did not rule out any patients who have life expectancies beyond that. And I think that's important mostly because a lot of the patients that we treat and we care for don't necessarily have that sort of longevity under their belt. But I think the big thing is this kind of, we thought we were able to elaborate at least more effectively that the findings in Best CLI really do promote a important treatment strategy in this patient population, which is primarily through managing them with single segment great saphenous vein if they have it. I think that's the big takeaway. Cohort 2 is a little bit more complicated, but I think that's important to highlight as well, that we still really don't have a good plan for these particularly sick patients who have CLTI.
You know, one of the other things at Best was to randomize somebody, you had to have an anatomical equipoise if it could be treated open versus endo, and how do you think that affected things here? Because you may have some task A's in your endo group, and you may have some people that very few people would try to bypass would try to do endo in your bypass group. So could you comment on that?
Yeah, I think that is kind of one of the several limitations that, and also this is sort of the old task classification system. Ideally, we would have used the GLASS classification system, but that would have taken, I think, months of chart review to do. So I think that's a little bit more helpful and thorough in terms of kind of diagnosing and prognosticating on these patients. But as was mentioned in the presentation, the majority of patients did have kind of more severe lesions, those task C and D lesions. And I think from an institution standpoint, we do try to follow those guidelines as best we can. But as mentioned in the manuscript, a lot of these patients in cohort 2 were probably too sick, did not have a vein graft for bypass, and were getting angioplasty in some way for these very severe task D lesions, which is obviously not recommended, but a lot of these patients, you know, you kind of want to do something for them, and this might be able to give them at least a shorter course of relief, despite them having, you know, poor perfusion to their feet. So
We had a question in the chat from Dr. Lee. Has anything changed in your institution after this study?
from my perspective, so I obviously don't make many decisions from a clinical standpoint. And Dr. Stangenberg can
Yes, you
correct
do.
me. That's fair.
We do everything that you said, tell us, Jeremy, especially at 2 o'clock in the morning. No, I think what has changed is we really strive to have vein mapping available to us before we put the patient on the table for the first angiogram, either in form of a formal vein mapping, if it can be arranged. Sometimes logistically that's a bit difficult, but otherwise the vascular resident or the fellow who's doing the case with the attending will take an ultrasound quickly in the pre-op area or latest on the angio table to get a sense of whether vein is available. Because depending what we find, let's say it's a very complex, not a complex, but it's a long lesion in the SFA, and eventually there's maybe a BK pop target very distally, and I know I have great saphenous vein, I will not struggle mightily to get through this. But if I know that there is just no conduit available, then, and knowing that between at least best CLI showed similar results and we show now similar, our old patient population have similar results, there's like really hit or miss between an endo approach or an alternative conduit, then if it's a reasonable lesion, then I will be more aggressive endo, for example, if it's at all achievable.
Another question in chat. What, Dr. Nagarsheth, what do you think the high number of patients who received above knee interventions for CLTI? Are you seeing a lot of people with just isolated, SFA disease with CLTI?
Yeah, that's a
Fair bit
good.
of AK pop bypasses and everything there.
Yeah, that is definitely a particular difference, especially in cohort 2 from our study with best CLI. I think we had double the number of above knee bypasses in that cohort, and I think primarily the difference from our perspective is that, as Dr. Lamb said in the presentation, rightfully so, this is a pretty rare patient population, patients who are coming to a vascular clinic and do not have any prior interventions. And I think oftentimes the preference is to, if they have, any single vessel runoff, and you can recreate inline flow to the leg, if you can do a more proximal bypass first, then you can hopefully save a follow-up bypass target, or at least another vessel to touch up in the future if you can. So I think that's probably where that high proportion came from. Again, that's very different if this is a third, fourth intervention in a patient who has had 1 or 2 failed bypasses before, then you would start to try to go a little bit more distal. But I think that is a big distinction in our study in best CLI.
Thank you for that awesome presentation, and keep those questions coming in on the chat. I'm sure they'll get answered. But at this point, thanks to the authors and moderators for that first paper. And I'll now invite Dr. Mulaini Topkar and Dr. Ramadan. I think we have 2 presenters on our next one, and Dr. Dua, to go through the impact of the ERAS protocol with multimodal anesthesia on the perioperative outcomes after open AAA repair.
There we go. Can everyone hear me? Can you all hear?
Sound good. Thank you.
Yes, lovely. It's so great to see you all today. We're just so thrilled to be a part of this. This is our inaugural joining of the JVS Journal Club, and there's a wonderful array of our residents and faculty here. So thank you so much for having us. And we're especially excited to be presenting this paper because it's actually so timely. At the end of the day right now, we all know that in medicine, there are really 2 things going on. There's, of course, care of our patients. That has been the standard of, the way that we function, at least for hundreds of years. But the other thing is, of course, the administrative push to get patients out, to make things more efficient, to make sure that, the clinical aspects are aligned with the administrative and the financial aspects. And so the beauty of ERAS, which, all of us have been exposed to at some point, especially if you've done general surgery, is this idea of having a clinical pathway that really allows us to focus down on the right things for the patient in a standardized fashion, with ultimately the goal of getting the patients out quickly, but also making sure that they're safe, reducing things like bounce back, and ensuring that the things that we have in terms of metrics, like, for example, in terms of like colorectal surgery, something like bowel function, comes back better and faster than if you just did things differently between different attendings. And so this has been a point of contention sometimes between the administration, so to speak, and clinicians, because what's best for the patient may sometimes not be best for the hospital. But ERAS is beautiful in that we get to kind of come together and talk about something that aligns in both regards. Now, vascular surgery, unfortunately, in this particular realm, in terms of using ERAS protocols, has been a little behind the times. As I mentioned earlier, the colorectal world really is what picked up on it. General surgery picked up on it. And through their success, we now have certain aspects that we focus down on in terms of the comprehensive patient care to ensure that they get optimal outcomes. And for, now the first time we're going to be able to see this applied to open AAA, which is of course something that all of you know, in all the different hospitals that you sit at, we have issues with. Our ICU does certain things we're not happy with. You have to go and you've got to tweak areas. And if there's a different attending on, you might not get the same standard of care and level of care for each one of your patients. But with something like the implementation of an ERAS protocol, you basically will have a standardization. And here in this particular paper, my colleagues are going to be talking about some of the data that focuses around optimal outcomes when you implement the ERAS protocol. So without further ado, I do want to introduce our excellent presenters. We have our junior and our senior presenters who are in fact junior and senior vascular trainees. We have Bianca, who's our second-year resident, who will begin by presenting, followed by Dr. Ramadan, who is our current junior fellow, very soon to be senior. So look forward to all of your questions, and you look forward to the greatest presentation ever. Bianca?
Thank you, Dr. Dua, and thank you everyone for the opportunity to present tonight. We're going to be presenting a paper by Dr. Dunham and colleagues out of Florida Atlantic University on the impact of enhanced recovery after surgery, or ERAS protocols, with multimodal anesthesia on perioperative outcomes after open AAA repair. The impetus for this paper was because historically open AAA repair has had high perioperative risk, and ERAS protocols, especially in other surgical settings, have been shown to improve perioperative outcomes. And although ERAS protocols are widely adopted in other surgical specialties like colorectal surgery, and there exists ERAS protocol for open AAA repair, it is not as widely adopted as standard of care. So the goal of this study was to assess the impact of an ERAS clinical pathway for open AAA repair. I'm going to go through the components of the ERAS protocol that the authors used for this study. It involved 4 main components, ranging from the pre-admission phase to preoperative, intraoperative, and then postoperative phase. And the details of the protocol are here. There are a couple of features of the protocol that I want to highlight in particular. One is that they stopped aspirin 5 days before surgery. 2 is that they encouraged clear liquids up to 2 hours before surgery. 3 is that all patients received a paravertebral catheter, PVC, at T10 to 11 preoperatively. 4 is that blood products were used judiciously with cell saver prioritized. 5 is that multimodal pain management was employed with PVC infusion, scheduled IV Tylenol to limit opioid use post-op. Feeding was also an interesting aspect. Patients actually advanced to a solid cardiac diet on post-op day 1, and their NG tubes were removed when the patients were extubated. And then early mobilization with physical therapy, out of bed to chair, starting on post-op day 1. The study design was a single-center retrospective review. All patients who had undergone who had an aortic iliac aneurysm below the level of the celiac artery and were undergoing elective repair were included, including patients who had a prior EVAR. Those who had mycotic aneurysms or ruptured aneurysms or were treated in a more emergent setting were excluded. There were 160, so basically the ERAS protocol was implemented at this institution in 2021. And before the implementation of this protocol, there were 161 patients who were included from 2013 to 2021. After the ERAS protocol was implemented, 80 patients were included from 2021 to 2023. Patients in the ERAS group were matched to the pre-ERAS control patients using one-to-one nearest neighbor matching along the following factors: age, gender, BMI, the VQI AAA mortality risk score, the Rockwood frailty score, aortic cross-clamp location, aneurysm size, and type of exposure performed, transperitoneal versus retroperitoneal. And then descriptive statistics were calculated comparing the two groups, either using t-tests or chi-square or Fisher's exact test, depending on the distribution underlying. And then quantile and logistic regressions were also performed on primary and secondary outcomes. The outcomes were primarily length of stay and early mortality, which included both 30-day mortality as well as in-hospital mortality. Secondary outcomes included rates of 30-day readmission, rates of early major complications, of which there were 8, including AKI requiring dialysis, bleeding needing reoperation, limb ischemia requiring intervention, mesenteric ischemia, spinal cord ischemia, a major cardiac event, a major pulmonary complication, and acute stroke. And then the 2 other secondary outcomes included were post-op opioid consumption and hospital cost. Looking at results for our baseline characteristics, just in general, over 70% of the cohort was male with a median age of 74. Before matching, of note, the post-ERAS group, so after 2021, had lower AAA size, VQI predicted mortality. You can see here highlighted 2.9% versus 4.9%, a lower incidence of prior EVAR, a lower rate of transabdominal exposure, and a lower rate of suprarenal cross clamp. After matching, most of these differences were corrected, and the only 2 main statistically significant differences were hypertension, which was higher in the ERAS group, and transabdominal exposure, which was lower in the ERAS group. So the ERAS group had a higher rate of RP exposure. In terms of primary and secondary outcomes, overall, the ERAS group had a lower median length of stay, and these are all statistically significant at a p-value of less than 0.05, 3 versus 6 days at the median, a lower rate of post-op opioid consumption over the first 72 hours post-op, 24 versus 59 morphine milligram equivalents, a lower hospital cost, on average $4,775 lower for the hospital stay, and a lower rate of major complications, about half the rate, 11.3% in the ERAS group versus 22.5% in the control group. There were no statistically significant differences between the groups in mortality, readmissions, or non-home discharges, meaning discharge to rehab or SNF. And of note, even though these weren't statistically significant, mortality and readmissions were a lower rate. Using logistic and quantile regressions, similar results were obtained. So a reduction in length of stay by 3 days for the ERAS group, reduced opioid consumption by 37 morphine milligram equivalents, and lower hospital costs by $4,700, with no statistically significant difference in major complications, mortality, or readmissions. Looking at the 8 major complications, the ERAS group in particular had statistically significant lower rates of cardiac complications, including MI, 2.5% in the ERAS group versus 12.5% in the control, and pulmonary complications, 2.5% in the ERAS group versus 11.3% in the control group. There were no significant differences between the groups in rates of AKI, postoperative bleeding, acute leg ischemia, spinal cord ischemia, major stroke, or major wound. And it's thought that the decreased rate of pulmonary complications could be potentially attributed to the early extubation protocol, because there were very few patients in the ERAS group who were still on a ventilator after 48 hours after surgery, with notably no significant increase in rates of reintubation despite that early extubation protocol. In terms of non-major complications, the ERAS group had lower rates of postoperative administration of packed red cell transfusions, 6.3% versus 17.5%. Lower rates of delirium, 8.8% in the ERAS group versus 20% in the control. Pneumonia, 1.3% in the ERAS group versus 13.8% in the control. And there were no significant differences between the 2 groups in the rates of DVT, wound infection, being discharged on home oxygen, post-op ileus, UTI, urinary retention, or minor stroke or TIA. So overall, on average, the non-major complication rate was lower in the ERAS group, was about 30% compared to 50% in the control group. And finally, 2 more categories of results regarding intraoperative fluid management, which was a component of the ERAS protocol. Overall, patients who were in the ERS group had about half the amount of volume that they were administered, 3.5 liters versus 7.2 liters, and half the amount of crystalloid, 2.5 liters versus 5 liters, and significantly less packed red cells, 0 versus 500 cc's intraoperatively. Time to functional recovery was overall faster in the ERS group. Time to extubation was on average 1 hour in the ERS group versus 13 hours in the control. ICU length of stay, Foley removal, ambulation, advancement to a solid diet, and bowel movements all happened on average a day or two earlier in the ERS group compared to the control group. And this could potentially be attributed to the early feeding and ambulation protocols in the ERS protocol. I'm going to hand it over to Omar for the last part of the talk.
Hey, good evening. Just to kind of diffuse this down to some key takeaways here. So first is regarding the multimodal pain control that they implemented specifically in this institution's case, the use of paravertebral blocks as well as scheduled Tylenol, the ability to reduce their postoperative opioid use within 72 hours by greater than 50%. Secondly, their ability to decrease their cardiopulmonary complications, likely attributable to both the early extubation push, as Bianca mentioned, as well as their significant reduction in intraoperative fluid administration and their utilization of balanced resuscitation in the OR. Kind of as a consequence of their ability to use fewer opioids, avoid the ICU, remove lines sooner, they also saw decreased rates of post-op delirium, which we're all aware can lead to substantial morbidity and increased length of stay in the hospital. And then again, kind of in totality, they were able to reduce length of stay substantially and as a result, hospital costs. And notably, I think, importantly, without increasing readmissions or non-home discharges. So they weren't just pushing people out that just came back 10 days later, and they weren't all going to SNFs. There are some limitations we wanted to highlight as well. I think the first is the generalizability. This paper benefits from a very structured program honed in by a single surgeon, and for the ERAS portion of it, a single anesthesiologist. Obviously, that's not generalizable to all institutions, and that is worth noting. It's difficult to have that kind of uniformity in care. The pre-post design of the paper meant that there was no contemporaneous control group, and it was analyzed over a 10-year time frame. And so there are some obviously problematic issues with that. There are a lot of changes in healthcare in the past decade. One, as Dr. Dua mentioned, is really a nationwide administrative shift towards improving length of stay throughout the hospital, and that's meant increased alignment of social work, physical therapy, even like home care to facilitate earlier discharges. And so it's hard to untangle that piece entirely from the treatment portion of the group. Of course, over time, in theory, the surgeon, the OR team that's working with this surgeon, and the floor and ICU teams are getting more and more familiar with the care of these patients, and so their performance and their ability to rescue patients after complications probably improved as well. And then, there's some heterogeneity in approach in the groups. The ERAS group is almost uniformly RP approach patient, made up of almost uniformly RP approach patients, 97.5%. In the control group, there was more heterogeneity, about 20% underwent transabdominal approach repairs. Obviously, a paravertebral block is probably less likely to be effective for transabdominal approach, so that's one point. And it's unclear if we are seeing to some effect, the benefits of the RP approach in general, since that's essentially synonymous with the ERS group here. It is also unclear to us the type of pain control that was used for the control group. I'm sure it was heterogeneous over time, but I was curious to know what proportion of them underwent epidurals. And then finally, some heterogeneity in pathology, although a lot of these differences were not statistically significant, they were notably generally higher in the control group. So higher rates of suprarenal clamp, higher rates of EVAR explants and bifurcated grafts, and then significantly increased operative time, perhaps all suggesting that there is some level of increased complexity of cases in the control group relative to the ERS group. All right, well, thank you for listening to our presentation. Thank you to Dr. Dua and Bianca for putting this together. Thank you for having us, and thank you to the authors for a great paper, and we're happy to take in any questions.
Very nice job, both Bianca and Omar. Awesome job. And it's great to have the group from the Massachusetts General Hospital here with us tonight and reviewing this paper. I want to say thank you especially to the group at Florida Atlantic University, Dr. Dunham, Dr. Lee, and your co-authors for presenting such an extensive series with very granular data and allowing us here in this journal club to kind of pick it apart and to ask you some questions. Thanks for coming to the table. I want to start things off, and while I start off, I just want to encourage anybody online, feel free to post in the chat, and I will review and ask the question for you. In the meantime, I think Dr. Ramadan did a nice job highlighting a couple of the questions that I had come to mind when I read your paper, and I'm sure are shared by some of our other listeners here tonight. So perhaps Dr. Dunham and Dr. Lee, you can kick it off by commenting just on the nature of this cohort. By my read and by the elucidation here of Dr. Ramadan, these appear to be predominantly from the side, suprarenal clamp. Are these all thoracoabdominal aortic aneurysms? Are they paravisceral? Are these EVAR conversions? What is the nature of these? And what about the standard, chip shot apollonistic infrarenal EVAR? How do you approach those differently? And does this care path still apply in that case?
Yes, thank you. I just want to say, Bianca and Omar, thank you. It was a great presentation. It's really cool to see the paper I worked on, having someone put this much time into it to actually, present it so well. And the PowerPoint was also very well done. So I want to thank you for that. Regarding the question, can you just repeat the last question you had?
Yeah, if you wouldn't mind, help us understand a little bit better the nature of the cohort that underwent surgery. By my read, especially here in the ERAS era, the majority of these people had an RP from the side approach and a suprarenal clamp. Are these conversion EVARs? Are these thoracoabdominals? And would you apply the same care path to the apollonistic infrarenal EVAR that you might do from the abdomen from the front? Would you also remove the NG2 post-op and feed them on post-op day 1?
Yes. So this pathway did apply to anyone who, it was not thoracoabdominal aneurysms. It was anything below the celiac. So it was not thoracoabdominal, and we would apply the retroperitoneal approach to pretty much any case. It's Dr. Lee's preference. He finds the exposure to be, it works for almost all of his cases. There's a few limitations to it, but really he's able to use it in almost all the cases. And then regarding the paravertebral catheter, it does pair well with the retroperitoneal exposure. So I think he still favored it throughout really the entire cohort. But with the anesthesiologist that was placing the paravertebral catheter on every patient, it does, it delivers great anesthesia that's a bit more specific for the retroperitoneal approach versus the transabdominal. You're going to get dermatomes bilaterally. So it's a little bit limited there.
So coming from a general surgery background, having slaved for 7 years in a residency, and it was beat into my head, you leave an NG tube in until they pass flatus. You don't feed them for several days. This is obviously quite an evolution. Do you think that you were able to feed these people because of the RP approach or because of something else in your care path?
I mean, I think the RP approach does play into it, not manipulating the bowel. But the patients that had transabdominal approach, we wouldn't leave an NG tube in them just because of that. So they would still have, upon extubation, they would still have the nasogastric tube removed. So it wouldn't really play into, we kind of give everyone a shot. We could always place a nasogastric tube back in, but we don't just leave it there with the idea of, will an ileus develop? And there's literature supporting that. There's microaspirations that occur when you have a nasogastric tube in. So I think there's a place for a nasogastric tube, but I'm still having to push that every day. I'm in a general surgery residency, and I work at a few hospitals, and some of the hospitals we go to are very old school. So yeah, nasogastric tube, but it's pretty it's a personal thing for me. I really hate them unless they're indicated. And that's really
Thank you.
the whole ERAS protocol is really the idea of, it's not one thing. It's just making sure that every patient gets the best shot with, getting the check mark with every single aspect throughout their, hospitalization, preoperatively, intraoperatively, postoperatively. So it's less like one thing, I think. And with other literature and more colorectal, they have really hard time specifying what aspect of the protocol is beneficial, rather just having the entire protocol that you follow. It has the benefit when it's summed together.
Thank you.
Bjorn,
I think I'm sorry, go ahead, Dr. Lee, please.
yeah, Bjorn, let me just make one commentary here. It's what you just said prior to Alex's response. You've toiled away for 7 years as general surgery resident. All this thing about NG tube. I think the real issue is, who actually studied that? I think so much of what we do, somebody made it up, and it seemed like a good idea, and it seemed to make sense. And a lot of our long-held beliefs have never been really challenged. And I think what ERAS does is truly challenge that and say, what does happen if you take the NG tube out right away? Do people die? Do people aspirate? And I think one of the take-home messages is that no, people actually do okay. They tolerate food on post-op day 1, and I think that people should take away from this kind of a bold experiment, if you will, and challenge other long-held beliefs that really have no scientific basis, and no one really formally studied it. Anyway.
I think that's well put. And now I'm going to push it right back to you with the following question, because the long-held belief in general surgery was stop aspirin before any surgery, major bleeding. And you stop it several days before these approaches. Whereas
Yes.
now I'm being told we operate on aspirin all the time, open aneurysms, leg bypasses, you name it, because we're worried about the cardiovascular risk factor in these patients. What makes you say it's safe to stop it? And what made you say, let's go ahead and do this rather than keep aspirin on board?
Well, a famous aortic surgeon once said the problem with aortic surgery is not clotting, it's bleeding. And I have to tell you, I'm even in the absence of a level 1 data, I prefer to optimize my chances of non-bleeding by stopping aspirin 5 days or even longer than take a chance on that. Does it merit a formal study? Maybe, maybe not. But I guess it's kind of my preference.
Thank you for clarifying that. Just want to highlight one of the comments from Dr. Yajur. I'm sorry if I'm not pronouncing that correctly, but who said it's important to highlight that in the transabdominal approach to an aneurysm repair, we only briefly touch the intestines, and that's to quickly move them out of the way. We're not doing heavy surgery on them or manipulating them. So most likely goes to justify, again, that we may not have the same level of ileus even in that setting. Another question to you is that, again, Dr. Ramadan brought up this point. You've gone a long time ago to more recent. And yes, you implemented this care path in the more recent time period. But what else has changed in your own practice and in your institution over time that you feel may have led to some of these better outcomes you're noticing? Is it all the care path, or is there something else in the mix that perhaps we can copy at our institutions?
Maybe I should take that question, Alex. From a historical perspective, I really do think a lot of this is directly attributable to the changes that took place during the 3 years of the so-called post-ERAS study. Especially in terms of intraoperative management of fluids, as well as postoperative or perioperative pain management. I think the aspect of multimodal anesthesia and in terms of having a kind of a regional block component, as well as the traditional analgesic methodologies really contributed to the results. So, and we didn't have that prior to it. So the simple answer is yes, I think the ERAS with the multimodal anesthesia really were the principal components of these changes in the outcomes.
That's great. Thank you. I'm going to take one question here from the chat from Dr. Nagashev. How do we reconcile such a difference in transfusion between the two cohorts? Was there less blood loss in the ERAS group, or was it a higher resistance to transfusion? In other words, did you change your threshold at which you might be inclined to give a blood transfusion, either intra-op or post-op?
Yeah, well, I have to tell you, I've been doing this for a long time, and what has changed was actually the intraoperative management. Prior to it, I guess there was less consciousness in terms of restricting intraoperative fluids, and in fact, there was a lot of crystalloid given, and in the kind of post-ERAS era, there was more awareness of it, and that was and far less fluids were given, and resulting in less dilutional anemia, and which we all recognize, and obviously less transfusions were required.
Right. Thank you. I think we're winding down. We have no other questions in the chat. I don't have any other burning questions. I just want to thank you again, Doctors Dunham and Lee, for coming to join us tonight and allowing us to review your paper. And again, congrats and thank you to the group at the MGH, Dr. Ramadan, Mulaney Topka, Dr. Dua, and all your colleagues for coming and presenting this paper tonight. In the chat, there is a reminder that we will not be meeting in the month of June. We will reconvene in July, on July 9th. And that's all I have. So thank you, everybody. Have a wonderful night.
Thank you.
Thank you.
Bye.
Thank you.